Hello, I would like to thank the anesthesiologists who work hard day and night to perform high-risk surgeries and perform high-risk anesthesia.
Hallo, ich möchte den Anästhesisten danken, die Tag und Nacht hart arbeiten, um risikoreiche Operationen und Narkosen durchzuführen. Hola, me gustaría agradecer a los anestesiólogos que trabajan duro día y noche para realizar cirugías de alto riesgo y realizar anestesia de alto riesgo.
Welcome to our deep dive into the foundational principles of intraoperative echocardiography. Whether you're just starting your journey with TEE or you're a seasoned practitioner looking for a solid refresher, this explainer is designed for you. We're going to cover everything from the nuts and bolts physics that make it all possible, all the way to the standard views that form the bedrock of our practice.
We've broken down our journey today into 4 main parts. First, we'll kick things off with the absolute fundamentals, the physics of ultrasound and the different imaging modes we use. Then, we'll peek under the hood and look at the scanner technology itself. Part 3 gets really practical, focusing on the equipment, crucial safety considerations, and the right technique. And finally, we'll bring it all together in Part 4, where we'll walk through the comprehensive TEE exam and master those standard views.
All right, let's jump right into Part 1. You know, before we can even begin to interpret the incredible images TE gives us, we really have to have a solid grasp on the physics that create them. This part is all about understanding the how that happens behind the scenes every time you pick up the probe.
So at its most basic level, echo is all about ultrasound. And what is ultrasound? It's just sound waves, but at frequencies way, way above what our ears can detect. We send these high-frequency waves into the body, they bounce off the heart and other structures, and the probe, our transducer, listens for those returning echoes. Now, there's a fundamental trade-off here that you are always going to be balancing in your practice, and it's this. Higher frequency gives you a beautiful, high-resolution image with crisp detail, but it can't penetrate very deep. On the flip side, a lower frequency can see much deeper into the body, but you sacrifice some of that image clarity. It's the constant balancing act we perform with every patient.
Now, the ultrasound beam isn't just a single line. It has a shape, kind of like the beam from a flashlight. Right up close to the probe, we have what's called the near field, or the Fresnel zone. Here the beam is nice and tight, columnar, and focused. This is our sweet spot. This is where the magic happens for imaging. As the beam travels further away, it enters the far field, or Fraunhofer zone, and it starts to spread out, to diverge, and lose its focus and intensity. So the practical takeaway is simple. Whenever possible, you want to position the probe so that your structure of interest is sitting right in that near field to get the sharpest, most accurate image.
As that beam travels through the body, it's not just a straight shot. It interacts with tissue in 3 main ways. First, you have reflection. This is pretty straightforward. The waves hit a large, smooth surface, like the pericardium or a valve leaflet, and bounce back cleanly. Second is scatter. This happens when the waves hit tiny things, like individual red blood cells. They bounce off in all directions, and this is what actually creates that classic, granular, speckled texture of the myocardium that you see on the screen. And finally, there's absorption. This is where the tissue literally converts the sound energy into a tiny amount of heat. This absorption is the main reason our signal gets weaker, or attenuates, the deeper it tries to go.
And this slide right here, this brilliantly illustrates why our job can be so challenging and why acoustic windows are everything. Just look at these numbers. Water, fat, soft tissue, the attenuation is super low. The signal passes through almost perfectly. But now look at the bottom of the table. Air has a coefficient of 12, bone is 20, and lung tissue is a whopping 40. This is precisely why we can't just image through a rib or through an air-filled lung. The signal gets so heavily absorbed and scattered that basically nothing makes it back to the probe. It's why TEE is so powerful. We get past all that stuff.
Okay, so with that physics foundation firmly in place, let's now look at how the machine cleverly uses all those principles to create the different imaging modes we rely on every single day in the OR. We're going to start with the most basic building blocks and work our way up to the really sophisticated 3D reconstructions.
The 2 most fundamental modes you'll use are M mode and B mode. Think of M mode, or motion mode, as an ice pick view. It sends out a single line of ultrasound and just plots what it sees along that one line over time. Its temporal resolution is absolutely phenomenal. We're talking over 1,000 frames per second. This makes it the perfect tool for precisely timing cardiac events, like valve opening and closing, or getting super accurate measurements of wall thickness. B mode, or brightness mode, on the other hand, is what we all think of as the standard 2D echo image. It sweeps that ultrasound beam back and forth to build that real-time moving anatomical picture of the heart, which is, of course, essential for understanding the structure and function. All right, let's talk about harmonic imaging. This is a really cool piece of tech that has dramatically improved our 2D images. Here's how it works. The machine sends out sound waves at one frequency, let's say 3.5 megahertz, but then it cleverly listens only for the echoes coming back at double that frequency, so 7 megahertz. This second harmonic frequency is actually generated by the tissue itself as the sound passes through. So what's the big benefit? It cuts down on a ton of noise and artifacts, especially in that near field we talked about. The result is a much cleaner image with way better definition of the endocardium. Honestly, it's a button you'll almost always want to have turned on.
And now we get to the real powerhouse of hemodynamic assessment, the Doppler effect. You already know this principle from everyday life. It's what makes an ambulance siren sound higher-pitched as it's racing towards you and lower-pitched as it moves away. We do the exact same thing with echo. We send ultrasound waves that bounce off moving red blood cells. If that blood is moving toward our probe, the returning frequency is higher. If it's moving away, the frequency is lower. By precisely measuring that frequency shift, the machine can calculate the exact velocity and direction of blood flow anywhere we point the beam. It's truly amazing.
Okay, this is a critical concept. We have two main types of spectral Doppler, pulsed wave and continuous wave. You have to know the difference. Think of pulsed wave, or PW, as your sniper rifle. It lets you place a tiny sample volume at a very specific spot, say right at the mitral valve leaflet tips, and it measures the blood velocity only at that one location. It's incredibly precise, but it has a speed limit. When velocities get too high, it gets confused and aliases. That's when you see the signal wrap around on the screen, giving you a totally wrong number. It's like seeing a fast-spinning car wheel look like it's going backwards. On the other hand, continuous wave, or CW, is your shotgun. It has no speed limit. It can accurately measure the fastest, most turbulent jets, which is why you will always use CW to measure the peak velocity across a type aortic stenosis. The trade-off? It measures every single velocity all along the entire line of the beam, so you lose that pinpoint spatial location.
And the great thing is you can actually see this difference on the screen. Take a look at the left image. That's a pulse wave Doppler of mitral inflow. Notice how clean and sharp that signal is? It has a hollowed-out look. That's because we're measuring a uniform velocity at one specific point. Now look to the right. That's a continuous wave Doppler signal. See how the whole thing is filled in and fuzzy? That's called spectral broadening, and it's happening because the machine is displaying all the different velocities it's detecting along that entire beam path all at once.
We also have a few other Doppler tools in our toolbox. There's something called high PRF Doppler, which is kind of a hybrid mode that tries to measure velocities that are a little too fast for normal PW Doppler, but it comes with a bit of a trade-off in range accuracy. And then, of course, there's color flow Doppler. This is basically thousands of little PW sample volumes spread across the 2D image. The machine then color codes the velocity and direction, superimposing it on the anatomical picture. The standard map is BART, blue away, red toward the transducer. It gives us that incredibly intuitive real-time map of blood flow.
And that brings us to the modern era of 3D imaging. Modern probes can do this in a few different ways. Live 3D gives you a real-time but fairly narrow pyramid-shaped volume. It's great for a quick look. 3D zoom is incredibly powerful. It lets you draw a box around a specific area, like the mitral valve, and see it in a magnified real-time 3D volume. Surgeons love this for planning repairs. And finally, full volume mode acquires data from several heartbeats and stitches it all together to create a large, beautiful 3D dataset of an entire ventricle or valve, though you do sacrifice that real-time capability to get it. So, we have the physics down, and we understand the imaging modes. Now it's time to pull back the curtain and take a look at the sophisticated technology inside the scanner itself. This is the brain of the whole operation, the powerful computer that processes all those raw echoes into the clinically useful images we depend on. When it comes to image quality, resolution is everything, and we have to think about it in 3 dimensions. Axial resolution is our ability to tell apart two objects that are lined up one in front of the other, right along the path of the beam. We make this better by using higher frequencies. Lateral resolution is telling apart two objects that are side by side. We improve this by focusing the beam to make it as narrow as possible. And finally, elevational resolution, which is determined by the thickness of the ultrasound slice itself. Understanding these helps us intelligently adjust our settings to optimize the image for whatever question we're trying to answer.
Before an image is even saved to memory, it goes through what we call pre-processing. This is where we use our most basic controls. The most common one is gain, which is really just an amplification knob, like turning up the brightness on your TV. It makes the whole image brighter or darker. Other pre-processing controls help fine-tune the signal and reduce electronic noise. The really crucial thing to remember here is that these adjustments are made to the raw analog signal in real time before it ever gets turned into a digital file. You can't undo them later.
Okay, so after that initial signal is acquired and pre-processed, it starts its journey through the digital guts of the machine. First, an analog to digital converter takes that continuous wave of information and chops it up into discrete digital data, ones and zeros. Then, a digital scan converter takes the pie wedge shape of the scan and cleverly reformats it into the rectangular display we see on the screen. From there, the machine might use clever tricks like time averaging to smooth out the image and improve the signal-to-noise ratio. And finally, it assigns a specific shade of gray to every single pixel based on the intensity of the echo it represents, creating the final image that we get to interpret.
All right, with that firm grasp of the technology, let's now pivot to the really practical, hands-on aspects of TEE. We're going to talk about the equipment we use every single day, the potential risks involved, which we must always respect, and the proper, safe technique for probe insertion, which is arguably one of the most critical skills we have.
So here it is, our primary tool, the multi-plane TEE probe. At the very tip, you've got a sophisticated multi-frequency transducer, which lets us switch between frequencies on the fly to optimize our image. We have two main control knobs. The large one controls anteflexion and retroflexion, that's bending the tip forward toward the heart or backward. The smaller knob controls side-to-side flexion. Then there's a separate button or dial that lets us electronically rotate that imaging plane from 0 all the way to 180 degrees. And critically, there's a temperature sensor built into the tip, a vital safety feature that will alert us if the probe gets too warm, protecting the patient from thermal injury to the esophagus.
We always have to remember that TEE is an invasive procedure, and it is not without risk. Now, major complications are thankfully very rare, but when they happen, they can be devastating. The one we all fear most, of course, is esophageal perforation. But we can also cause more minor mucosal injuries, bleeding or hematomas. In specific high-risk patients, there's always a concern for causing a variceal hemorrhage, and beyond that, we can see things like arrhythmias during insertion, airway compression from the probe itself, or even dental injury. Being acutely aware of these potential risks is the absolute first step toward preventing them. And this brings us to a really common and important clinical question, one that comes up all the time, especially for those of us who do a lot of liver transplant anesthesia. Is it actually safe to put a TEE probe in a patient who you know has esophageal varices? There's a very real fear of provoking a massive, catastrophic bleed. So let's take a look at what the actual evidence tells us.
There was a key retrospective study published in 2012 that looked at this exact question. They reviewed nearly 400 liver transplantations. Out of that group, 287 of the patients had documented esophageal varices and underwent TEE. Now think about that for a second. That's a huge group of very high-risk patients. So in that entire cohort, how many major variceal hemorrhages occurred? Just one. A single event. And even more importantly, that bleeding episode happened late in the case, after reperfusion, and they couldn't definitively say it was even caused by the TEE probe.
So what's the big take-home message for our daily practice? It's that while the risk is never ever zero, the available evidence suggests that TEE is a relatively safe monitoring tool, even in this very high-risk population. This helps us make a much more informed risk-benefit decision at the bedside. It doesn't mean we can be cavalier about it, but it does mean that the mere presence of varices is not necessarily an absolute contraindication when the information you'd get from the TEE is clinically vital.
All of this brings us to technique, because a gentle, systematic technique is paramount for safety. First, preparation is key. Make sure the probe is well lubricated. A gentle jaw lift with your non-dominant hand helps open up the posterior pharynx. Then advance the probe smoothly, always feeling for the resistance. You'll feel a very subtle give or loss of resistance as the tip passes the cricopharyngeus muscle and enters the esophagus. Once you're in, all further manipulation, advancing, withdrawing, flexing, should be done while you are actively watching the echo screen. And I absolutely cannot stress this enough. The most important rule is right there in bold. Never, ever force the probe if you meet resistance. It is so much better to stop, withdraw, and reassess, even use a laryngoscope if you have to, than to risk causing a perforation. Okay, we have arrived at the final and, I think, most practical part of our discussion today, actually performing the comprehensive examination. This is where we put everything together. We take our knowledge of physics, the technology, and our safe handling skills, and we apply it all to systematically evaluate the heart's structure and function using a standard set of imaging views.
To get all 20 of the standard TEE views, you really only need to master 4 fundamental probe manipulations. First, we can advance the probe deeper into the esophagus and stomach, or withdraw it back up. Second, we can turn the entire probe shaft clockwise or counterclockwise. Third, we use that large control wheel to antiflex and retroflex the tip. And fourth, we use the small wheel for side-to-side flexion. It's the skilled combination of these 4 physical movements, along with the electronic rotation of the multiplane angle, that allows us to navigate the entire heart.
A truly comprehensive and high-quality exam is not a random hunt for views. It follows a defined, systematic sequence. This approach is so important because it ensures that we don't miss anything and that every single cardiac structure is evaluated thoroughly and from multiple angles. We're going to start where most exams begin, in the mid-esophageal position, before moving on to the transgastric and then the upper esophageal windows.
The mid-esophageal, or ME, window is our home base, so let's spend some time here. Starting with the multiplane angle at 0 degrees, we get our 4-chamber view. This gives us a great look at all 4 chambers and both AV valves. Rotating forward to about 90 degrees gives us the 2-chamber view. This is your go-to view for the LAD coronary territory, because you see the anterior and inferior walls of the LV so clearly. Advancing the angle further to around 120 degrees gives us the long axis view, which is critical for evaluating the LV outflow tract and the aortic valve. The aortic valve short axis, that classic Mercedes-Benz view, is usually found between 30 and 60 degrees. And finally, the bicaval view, at around 100 degrees, is essential for looking at the intraatrial septum and guiding cannulation for cardiopulmonary bypass.
Next, we're going to advance the probe down into the stomach to get our transgastric, or TG views. Once we're in the stomach, we antiflex the probe tip to bring the heart into view, and this gives us the transgastric mid-short axis view. This donut view of the left ventricle is, without a doubt, the single most important view for assessing new segmental wall motion abnormalities and overall LV function. From this home base, we can get other crucial views, like the basal short axis for a perfect in-face look at the mitral valve, and the deep transgastric long axis, which often gives us the most parallel alignment for accurate Doppler assessment of flow across the aortic valve.
And of course, no exam is complete without a thorough evaluation of the aorta. By withdrawing the probe just slightly from the mid-esophageal position, we can get beautiful short and long axis views of the ascending aorta. Then, by turning the entire probe to the patient's left, we can scan all the way down the descending thoracic aorta, looking for plaque or dissection. Finally, by withdrawing the probe all the way up to about 20 or 25 centimeters from the incisors, and again turning left, we can obtain the upper esophageal views of the aortic arch and the great vessels, an absolutely critical part of the exam in any case of suspected aortic dissection or trauma.
You know, when we see a wall motion abnormality, it's not enough to just say, hey, the sidewall looks a little down. We need a precise, standardized language to communicate our findings effectively. And that's where the left ventricular segmental nomenclature comes in. It divides the left ventricle into specific, named segments, each of which can often be linked to a specific coronary artery territory. This allows for clear and universal communication with our surgical, cardiology, and critical care colleagues.
Historically, there have been 2 main models used for this. The 16-segment model divides the LV into 6 basal segments, 6 midventricular segments, and 4 apical segments. The newer and now currently recommended standard from the American Society of Echocardiography is the 17-segment model. It's almost identical, but it treats the very tip of the apex as its own distinct 17th segment, which they call the apical cap. It's a subtle difference, but knowing which model your institution uses is important for interpreting reports correctly and communicating clearly.
So we've taken quite a journey today, all the way from the basic physics of a simple sound wave to performing a complex, comprehensive examination of the entire heart. This incredible technology gives us a real-time window into our patient's physiology that is truly second to none. So I'll leave you with this final thought to ponder. As technology continues to advance, with things like real-time 3D and quantitative strain imaging becoming more common in the operating room, how is our role as anesthesiologists fundamentally changing? Are we evolving from simply being monitors of hemodynamics to becoming true frontline cardiac diagnosticians in the perioperative period? It's a really exciting future to consider. Thank you so much for joining me today.